the skin. Okay, so these are the objectives. We're going to review the skin, common skin conditions, and management, simple management. How do you differentiate between epidermal and dermal? Because I don't think she spent much time on this one, but I do think it is important because you're going to be the first liner. So you need to determine, what am I dealing with? Why is that important? So that you know which conflict you're dealing with. Now, if you're stumped and you don't know what you're faced with, what kind of rash, how do you refer? And when you refer, how do you console the patient such that you're not adding another DHS of fear? And a referral template, I'm going to present a referral template. All right, so the skin. Know that the skin, basic of it, has two layers, two basic layers. There are four. These are the first two. So epidermis is the topmost, and we call it in the medical term dermis, but in GNM terms, she calls it corium skin. The other two layers are the subcutaneous tissue, which is your layer of fat and connective tissue, and where all your arteries are, this one. Can you see my cursor okay?
Yeah.
And then the last layer is your fascia, which connects it to your bones and muscles. All right, now, so I'm going to focus first on the dermis. And it is this thick layer here. It contains your oil glands, your sweat glands, your hair follicles are here, nerve endings, and this is also where the arteries traverse. They don't reside here, but they traverse this layer. The delineating factor between the epidermis and the dermis is this ridge line here, which is called the basement membrane. Just an FYI, not necessary, but this is where your melanocytes, your color-producing pigments live. This is also the area where stem cells live. Stem cells are your baby cells. They haven't yet developed into the layers of the skin. They're just infants. And as they mature, they go up in layer. By the time they reach the topmost, they're the mature cells of the skin. So the growth happens in the epidermis. So that's the delineating factor between epidermis and dermis, this basement membrane. So dermis is a jurisdiction of the old mesoderm, and the control program resides in the part of the brain called the cerebellum. If you go back to our analogy of the layers of the brain and the brain control centers, we started with the KCT and the digestive, which is jurisdiction of the brain stem. So if you're in my analogy, I will always give this analogy. If you're building a house, that's your foundation. That's survival. That's why all conflicts are related to survival conflicts. Now, this is the cerebellum is the second layer, which is now the protective organs. Now you have your basic survival organs. You have to protect them now, and that is the jurisdiction of the cerebellum. That is where you will find issues related to layers protecting the lungs, linings protecting the digestive, linings protecting the heart. So it's all about protection. And it's also in the germ layer, old mesoderm. So this is GNM. You will rarely find me using the GNM drawings just because it's copyrighted. But whenever I cannot reproduce, I will use it. So this is their cerebellum control panel. And as you can see, we are out of the brainstem where laterality did not apply. So anytime you're out of the brainstem, any of these brain parts, laterality will apply. So we're in the cerebellum, and it's just showing you really just a general diagram of where the organs are. So here, pleura is the lining of the heart. Peritoneum is a lining protecting the digestive tract. And here you see the corium skin on each side. All right. With cerebellar adaptations, the tissue response will be one of, so the red is for the sympathetic phase, which is the conflict active. Blue represents vagotonic, which is slowing down, rest and digest mode. Because I could not reproduce their conflict active and healing phase. So this is conflict active, wherein the tissue response is cell proliferation or cell growth in general. And for healing phase, the tissue response is cell loss or decomposition. Therefore, when you have a rash that presents, a dermal rash that presents to you, what you will see are, in the conflict active phase, cell growth will be manifested as a thickening of that rash or a hardening of the rash. And I will let you know later how to tell whether a rash is hard or not. But the reason for that is the body is trying to seal off whatever it is that was perceived by the psyche as a conflict. So it starts to harden itself, to protect itself, create an armor for itself. As the tissue heals, then it starts the opposite tissue response, which is now breaking down. So now you have the ulceration. Do you have any questions about ulceration? Because I'm not sure if this is a mainstream term. This is used in medical terms.
Can you explain what that means?
So ulceration, just imagine excavation. It's excavating, it's creating a crater, it's creating a hole.
I always used to think that ulceration was like thickening, and I learned, like I've learned now by taking these classes, that I've got that backwards, that it's not the same thing. I thought it was adding stuff on, not taking away.
Okay. No, so imagine the crater of the moon. They're ulcerations, they're crater-like, they're excavations. And along with that cell decomposition, you will have what we call in the medical world pus. Usually pus is associated with infection. So, and I know, I'm aware GNM does not consider infection, but I will still use the word pus because it's more familiar to everybody. And abscess is a contained pus. So the body is trying to contain the debris. Necrosis is another word, a medical term for debris. Hold on a second.
Debris?
Debris, yeah. Yeah. The how do you say, when you have a construction site, there's mess everywhere. So
I thought I thought necrosis was like ulceration, was just like it's kind of decomposition. It's like a rotting, right?
You can have necrosis without ulceration. So ulceration specifically is an indentation, physical indentation.
Yeah.
But you can have necrosis without necessarily that skin ulcerating first. It will eventually. It will.
Can you give another example of what necrosis might look like? Like something
it's like an eaten out appearance. And usually it will have different colors now, not necessarily just pink. So it could look gangrenous. Grayish, blackish.
Okay.
Signs of rotting. That's what it is, rotting.
It's rotting, yeah. Decomposition.
All right. Do you have any other questions on this slide? None. Okay. So I'll move on. So the dermis conflicts are categorized into three main categories. They remember that you are in the jurisdiction of protection. So it's an attack on your protective mechanism. And there are three main categories of dermis conflicts. First is literally an attack. So all under the umbrella of attack. So it can be a literal attack. As you can see there, I outlined what could it be: surgery, a vaccination, a biopsy. It can be a figurative attack because we are able to abstract meaning from our day-to-day versus animals. And it can be just a fear, not necessarily in fact happening, but just a fear of future attack when you're anticipating surgery or when you're fearing harm to yourself. Hold on a second. I'm just gonna do something here because I cannot see myself. My slide. All right. Okay. So that's one subcategory of a conflict, of the dermis conflict, all about attacks. The second thing is all about contamination. When you are feeling dirty or defiled, something that you perceive as disgusting, and it's very personal. It's really up to you what you perceive as disgusting. For example, not to disgust you, but um, like because I grew up in a third world country, to me, flying cockroaches are somewhat normal. When I got here, it's disgusting for most people. So again, very, very much personal. Or you feel tainted emotionally. So there you have it, sexual trauma or being used in a relationship or feeling violated.
So I'm going to just step in and say there's a Bach remedy called crabapple, and it's used for exactly that. If someone has a conflict as such, that is a really good remedy to share
Under Bach.
under Bach. It's called crabapple.
And what does it do, Shar?
It's essentially everything that you spoke about. It's about their own self-evaluation, about how they're feeling about themselves, and it just, from my experience, helps them to soften and remember their truth.
Wow. I didn't know. That's awesome. So crab apple.
Crabapple.
All right. So we're gonna add that because later on we're gonna discuss management, and we're gonna add that to our apothecary, digital apothecary. So this is another sub category. The third subcategory for a dermis conflict is a feeling of incompleteness. So either you will feel broken, disconnected, or deformed. I tend not to read off my slides because they're pretty much readable. So if you have a question, just follow. You okay, moving on? So for all of these, if you get a rash that is associated with these conflicts, you will have in the conflict active phase a tissue buildup or growth. That's what you will see. And in the healing phase, what you will see is a tissue breakdown. It is the opposite for the epidermis. So we are now here on this topmost layer. This is now the jurisdiction of the cerebral cortex. And the germ layer is the ectoderm. Back to our analogy of a building that you're trying to build. So we're done with the survival brainstem. That's the foundation. On top of that layer, and in addition to that layer, you built your protection. Next to that layer that you build is the new mesoderm, which is all about the integrity of your structure. That is why the context related to that is all about self-devaluation, your personal integrity. Now, this comes as the last layer, the cerebral cortex, which is all about your relationship to the external world. So that includes all your senses. And the skin is a very big, major sense organ. So your conflicts will be related to a sense of separation from the external world as a big umbrella. And under that will be many subcategories. So focusing on the epidermis, if you can remember, this is the GNM outline or diagram for the control panel that is the cerebral cortex. And I don't necessarily see the epidermis here, but it's somewhere here. And what they're saying is it is close to the sensory area. If you focus your gaze on this right upper corner of the brain, side view, there are regions of the brain that are specific for motor function, specific for sensory function. So the sensory function is the green one. So the epidermis in the brain is in this area. The control panel is around this area. Now, the tissue response. Are you seeing this black bar here that I'm moving around?
No.
Oh, okay, good. So the tissue response now will be the opposite. So back to your building. The first two bottom layers, brainstem and old mesoderm, will have the same tissue response. Those are the old brain regions. Now, on top of that will be the new mesoderm, which is your integrity, structure, self-evaluation complex, and the newest layer, which is the topmost layer, cerebral cortex. Those two new top layers will have the same tissue response. So we are in the topmost layer of that building that you're building, that structure that you're building. So the tissue response is opposite to the dermis. So it will be one of cell decomposition and one of cell proliferation in the healing phase. Sorry, I forgot to switch my colors. This is supposed to be red still, and this is supposed to be blue. And under the conflict active stages for an epidermal rash, you may not even feel or see anything. What she's saying is at most you might feel numbness or thinning of the skin. Numbness because as a survival mechanism, the psyche is trying to numb us from the conflict that you just suffered, which is one of separation. And ulceration will be here, like syphilis, for example. Now, as it heals, that's when you start seeing the classic signs of redness, itching, warmth, blistering, depending if they have the syndrome, depending on how severe the blisters would be. Now, general rules. Okay, before the general rules.
What
Epidermis,
was after? Sorry, what was after peeling? Peeling, flaking, and blisters. Sorry, go ahead.
So for the epidermal conflicts, there are subcategories. The subcategories under the general umbrella of separation are either you're separating from a wanted physical contact. So you wanted it, but you didn't get it. Okay, so a person, an object, an activity. She's specifically saying it's not a house, not from a residence. So just make a mental note of that. I haven't been able to reconcile the rationale. Why not? But he specifically said, no, it's not about moving. Or just fear of losing, even though you haven't lost them yet. The second is loss of wanted emotional contact. Because again, we are able to abstract from our reality. So the symbolic is always a present umbrella as potential conflict. So you can have a separation from a loss of wanted emotional contact. And the third is a separation from an unwanted contact.
Wanted, unwanted. What was the first one? Sorry.
Let me go back to the first one. I'm going to give some examples. So loss of wanted physical contact from a loved one. So for example, a child will develop eczema on the arms after a pet dies. Just as an example. So missing the sensation of petting. Some generalizations, by the way, because this one, I did not create a slide for this one. If the rash presents as a localized area, so either hands or feet, localized, these are areas that are usually touched by loved ones or touched by an object. If the rash presents in a general form, there is no laterality at all, She's saying that the person suffered from the separation as a whole. If it presents on the inner aspects, what we call the flexure areas, inner aspect of the arm, for example, the inner aspect of the thighs, it's usually related to a loss of a wanted contact, either physical or emotional. But if you never wanted it, if it was separation from an unwanted contact, it could present on the outer areas of the hands, legs, body, because you're trying to push them away figuratively or kick someone away symbolically. So those are generalizations. And the skin lesions, the rashes, always appear in the healing phase. That's what she said on her notes. So for this one, separation, so the child having eczema from the death of a pet. A guitarist develops numbness on the fingertips after quitting music. So there might not be any skin rash yet, but the numbness could reflect conflict active phase. Or a psoriasis can flare up when a person remembers a past relationship and misses the touch of that person. So those are just examples for this slide. The second slide, loss of wanted emotional contact. A rash can appear on the face after a confrontation with a friend, like rosacea, for example. If they were told that you're not as beautiful, maybe. A child develops eczema all over the body after parents' divorce. That's another example. Now, the third one, unwanted contact. A child can get a rash in the diaper area, the bum, because they hate wearing diapers. The worker can develop, what's this? Dermatitis on the face from prolonged mask wearing. Or a student can get hives on the arms because of a subconscious desire to push away a controlling teacher. Maybe you can think of other examples. But those are just general examples. Okay. Now, the next slide, how do you now tell whether it's an epidermal or a dermal rash? Let me just see what my next slide is about. Okay. So in distinguishing, these are just, again, general rules. You're not required to diagnose rashes, but at least you're able to guide the individual. If you know more or less what kind of rash presented, then you can focus on what are the sub-conflicts and guide them in the counseling. So an epidermal rash, because it's superficial in its involvement, it may appear more pink or red. And why would that be? Why is a dermal rash more purple? Anyone?
Because it's deeper.
Because it's deeper. Just because visually there are more padding. There's more padding to the vision. So you can't see the arteries right away. That's it. And one thing that I do when I'm examining an individual is I just check the skin temperature with the back of my hand. If an epidermal rash would feel warmer, just because you're closer to the arteries superficially. Now the next line, check for texture. So observe the texture. Textures of epidermal rashes would be usually crusting, scaling. That's not thickening, that's thickening. While a dermal rash, because it's underneath, you might not even feel anything on the skin other than a smooth skin. Yes, it may swell. And one thing that I do in the clinic is I do a scrape test. If I have I usually have a glass slide in every room. With a glass slide, I scrape. If it's easily scrapable with a gentle scrape, you don't have to really be digging. If it's easily scrapable, that's usually an epidermal rash. The same thing with an oral thrush, by the way, the way we can tell, because sometimes it just presents as a white mouth and you don't even know, what is that? Is that milk or is that thrush? If it's milk, it scrapes off easily. If it's thrush, when you scrape it off, sometimes it bleeds and it hurts. Now, the next thing is, the next line, the third line is palpability. Feel it. You have to feel it. It's a rash. So usually a dermal rash will be what we call indurated, which means thick. It feels thick when you pinch it. And the blanching, it's harder to blanch because it's deeper. So you can just blanch with your thumb. You will just see if it blanches easily. And
Blanch means that it turns color. Is that what you mean with your thumb?
yeah, so when you press with your thumb, it turns pale. And then when you release it, it flushes back into pink again. So that blanches, that's what we call blanches easily. And if you do that and no color change, then most likely you're not dealing with an epidermal rash. It's deeper. Now, the itchiness, painfulness, tenderness, it really depends on what rash, but that, again, these are just generalizations. Epidermal rashes are often itchy. Dermal, not usually, unless they're hives. And yes, when they keep on scratching that rash, an epidermal rash will worsen. Any questions so far before I move on to the next?
I don't remember her talking about these.
I asked it. I asked it as a question, but I understand. I was just seeing if she would have some insights, but I wasn't expecting this because she's not a medical professional. She wouldn't know.
This is very helpful.
I thought so because you are the first liners.
Yeah.
You know how to differentiate. All right. So if you guys
Because that was kind of one of my questions afterwards, like after we were done the class, was like, really, how are we supposed to know the difference between epidermal and dermal?
Yeah. And again, these are how do you say? These are just guidelines, right? This is not set in stone because sometimes to me it looks epidermal, but when we biopsy, oh, it's a dermal.
Yeah.
So many rashes mimic each other, but at least you have a way. The reason I'm presenting is when you have someone in front of you, well, how do I know what conflict are they having? Because they are so different.
Mm-hmm.
At least you have an idea.
Well, and based off of the information that she gave us, we're going to have to memorize every single one of the type of rashes when.
Please don't.
Yeah.
No need.
That feels like it's a lot of work to do, but with this that you've just given us now, that it feels like less work, like if you know what I mean.
And that's the goal. You're not supposed to memorize these conditions because you're not diagnosing.
Mm-hmm.
That's not your responsibility. So stop memorizing. Your goal is to understand so that you know how to counsel which way to go, hospital or home. All right. So if there are no more questions on this slide, I'll proceed to the next one.
Richie, I have one question.
Yeah.
Sorry, and it's just kind of general. Maybe I should wait until the end of the skin session.
Go ahead. Oh, you don't want to ask it now?
No, I'll wait.
Oh, okay. Okay. So now you have a rash that is in the healing phase. What happens now if you have a KCT, right? So if you guys remember, the KCT is when they experience any of four or all of four conflicts. Can someone, does someone remember what the four conflicts are? Or just shout it out.
The
The four conflicts of KCT.
Yes.
Is it abandonment, hospitalization, refugee? What's the other one? There was one more. Just like fish out of water. Like
I believe it's separation.
Separation, yeah.
I think.
Abandonment.
Abandonment. Yeah, Fiona said abandonment, refugee, hospitalization, and then we're missing one, which in my memory, I think it's separation. I think it's separation. But anyway, so any of those four. So those ones, Amber, you do need to memorize.
Yeah.
Oh, it's life-threatening. Isn't it life-threatening?
Yeah.
Something's, yeah.
Yes. So we do need to memorize some. So if you're
Memorizing the conflicts, yeah. What I was talking about memorizing was the different types of rashes that she showed us.
don't do that. So if your client experiences any of those four or all four, last presenting to you with a rash, which is a healing phase of a skin program, then the syndrome will manifest as extra fluid. So the blister will be bigger, the swelling will be more intense. Anything under the syndrome is more intense of whatever you have in front of you. So the skin may appear puffy, weepy. If you've seen a rash that looks like it's weeping, crying, fluid oozing out, and the rashes may be prolonged if the KCT is prolonged. Now, so that's the syndrome. How does an epicrisis present in a skin program? So as you remember, the epicrisis is the body trying to expel the accumulated fluid. And with that, it will go back to mimic the sympathetic response, but in exaggeration. So the conflict active, everything under conflict active that you will see, exaggerated. It's a replay of the original conflict shock, but it's condensed into a brief, intense episode. And it's necessary for the person to move forward into the healing healing phase. So a rash during epicrisis will present as sudden worsening of the rash. So whatever it is that you're seeing under conflict active will be a sudden worsening of that. What else? It may involve fevers. It may involve chills. It may involve a temporary surge of anxiety, obviously for visible, like because visibly they will think, client may think it's getting worse. So that's an epicrisis of a rash. Everything exaggerated of the sympathetic response. All right. Now, she mentioned, if you remember, so the epidermis control program is in the sensory cortex. And she mentioned that with any healing phase, because the sensory cortex is linked to, plays a role in memory related issues. When there is a separation conflict, this disrupts the sensory processing and can impair cognitive clarity, leading to brain fog or a short-term, that's the key, short-term memory loss. So you might be confronted, and I get this all the time when because hair loss is epidermal according to GNM. Even though if you saw the diagram, the hair follicle is in the dermis. When I asked them why is it not a dermal program, why is it epidermis? They just told me it's epidermal. Take it as that. Okay.
Mm-hmm.
So then, okay, separation. When I ask my clients, when I interview them for the first time, did you go through a separation conflict? Most of them will not remember, do not remember the event. So 5 out of 10 would say, no, I don't remember anything happening during that time. But then again, it was years ago. So know that with the skin program, because of its association with the sensory cortex, it can present with memory loss or brain fog. It can present as a state of hypervigilance. The analogy that I can think of is when your computer freezes during a stressful rebooting. It's not a broken system, but it's just temporarily overwhelmed. Now, what else?
Sorry,
yeah.
Richie, I'm just going to say something because you were talking about memory loss and when you're talking to your clients. One of the things that when I'm talking to my clients about about fitness and stuff like that, like I have to find out what they used to do all the time. I was just like, you mentioning this made me think of, if somebody doesn't remember something that they were doing, like, or like if it was years ago that something happened, do you ever with them ask them like what their life was like what did you used to do, and like about things that are for fun or whatever? Because I know that a lot of times when I'm talking with people and they're going through health issues, they say when they were kids they used to be on a volleyball team, and that's something that they never ever do anymore. So that connection that they used to have back then is something that they no longer have. And why don't they have it? Did something happen that they all of a sudden they couldn't play volleyball anymore because their parents were like, you have to pay attention to your schooling now? And how did that affect them as they were growing older? And so when I'm helping people, I get them back into doing those types of things so that they're feeling more fulfilled in life. And I'm thinking like if it has to do with epidermis and separation, is there something in their past? Because talking about playing music, talking about doing sports things, talking about like doing fun things that they liked doing, that's a separation conflict, right?
Separation conflict. And
they might not remember, or they might not think it's a conflict, but it really, really was back then. But because of the memory loss, they might not really.
yes. So it's good to associate it with memories from the past that you were fond of, which may trigger a remembering. From my end, it depends on what kind of clinical visit I'm doing. If it's a hair consultation, which is like 15 minutes, no, I don't bring up the past. I just go.
Yeah.
But if it's a deep dive I'm doing, then yes, I will.
Okay.
All right, so don't forget skin rash episode or program may be associated with a short-term memory loss. The key is short-term.
Mm-hmm.
So sudden forgetfulness, brain fog. What else? The memory lapses may appear during the healing phase. And what else? So it's like the body is emotionally detaching from the painful disconnection. That's what it's trying to do symbolically. Now, all right. This I prepared for you. Let's just play. So what I did here are five of the most common adult rashes that you will see, and 5 of the most common pediatric rashes that you will see. And the reason I'm presenting them to familiarize yourself, because you can treat them at home. You don't need to refer. All right. So again, relax. It's I'm gonna try to see who answers the most so I can give that person a gift. All right, here we go. You guys ready? Name that rash. The first rash, adult rash. Touch the plant, touch some soap. Now your skin has lost all hope. Can anybody guess what
Dermatitis?
that?
Pardon?
That?
Dermatitis?
Mine.
Yeah.
Oh, hi, sorry.
Contact dermatitis.
Dermatitis.
Hi.
So yeah, poison ivy. You will see this. This is very common. And we will talk about how to manage them later because they all have something in common in management. Okay, next rash. Dry and itchy, cracked and red. Your skin just wants some cream instead.
Eczema.
Eczema?
Yes. Yep, or atopic dermatitis. One day smooth, the next all bumpy. Is your skin just allergic or just grumpy?
Psoriasis.
Think allergy.
Oh,
So someone
Hives.
yes, someone ate shrimp. Hive. Medical term is urticaria. Scaly, flaky, thick, and white. This rash just loves to hold on tight.
Psoriasis?
Yeah.
This one, if you try to scrape it, it's gonna bleed. And the more you scrape it, the more it forms. the worse it gets. And it's a silvery rash. It's different from dandruff. Dandruff is white. This one is kind of silvery. And the last one, no worm, no squirm, just fungus and
Ringworm. It's a
ring.
fungus.
Okay.
Now we go to the pediatric rashes. Baby's bum is red and sore. A little air will help for sure.
Diaper rash.
Diaper rash.
Diaper rash. Golden crust, not on toast. This rash loves face the most. Golden is the key.
Looks like impetigo.
Yes, it's impetigo. So they're classic for gold lesions, golden type lesions is what we call them. Just because they're pus.
It's quite common.
Tiny dots in what's that chart?
It's very common.
It's very common, yes. It can also happen, usually it's in the oral area. Tiny dots and itchy spots, a virus playing, connect the dots.
Chickenpox.
Yes, chickenpox. Yeah. See, so you're familiar with these. This might be the last one or not. Blisters here, blisters there. On hands, feet, and mouth. This rash ain't fair.
Mouth.
Mouth and foot.
So hand, foot, and mouth.
And foot, yeah.
Yeah, it's from the Coxsackie virus, which GNM does not recognize. So, now I'm thinking, okay, well, how does this happen then from GNM perspective? This might be the last one. Cheeks so red, it's quite the sight. Did they get in a pillow fight? This is very common.
Oh, it's that slapped cheek one.
Yes, you got it. Yes, slapped cheeks, or number 5, fifth disease, or erythema infectiosum. It's not a virus. And the way you will know is because it could look rosacea, right? But when you look closely, you will see the veins like a net interspersed with the red pinkish areas. So you will see like a net-like pattern, like a spider web.
What was that called again, Richie?
I would have to give this to Fiona.
So, but I just have a question about that slapped one. If you can go back. So what if it's a slapped rash or slapped cheek? Is it actually from a slap?
No, it's just just because they look like they were slapped.
Okay.
But
and I missed the name of that one, Richie.
The name of this one, it's slap cheeks, or fifth disease. Slap cheeks for layperson, they call it slap cheeks. Fifth disease, number 5, fifth disease.
And so what's the root of that?
It's from the medical term or world. It's from the Coxsackie virus.
Coxsackie, okay.
It's respiratory, like it's in the ear. It's respiratory.
Amazing.
Right. So award to Fiona. Sorry, there's no audio. I don't know how to bring up audio yet on Canva.
We can all clap.
So now, these are common rashes that you should be able to manage on your own. And you probably have been as moms.
Yeah.
Centuries and eons. So they have common generalities. So first is remove the patient or remove the trigger. Remove them from the offending agent. And if you guys have insights to share, just say it out loud. I'm sure you do. So for contact dermatitis, sometimes the known irritants are soap. Did somebody say something?
I think that was background noise.
Okay. So remove them from the plant. That's offending. If it's poison ivy, you know it's no brainer, right? Remove them from perfumed, whatever it is that they were using. If a cosmetic, remove the use or avoid the use for the time being that it's doing. The second is a gentle cleansing. What do you use for your own families for cleansers? Tea tree. Someone, are you guys still there? Because I can't see.
Yeah.
Okay. Salt water, tea tree oil, anything you want to suggest or
Cast-
share that you use at home?
like the Castile soap is really good.
Castile
Mm.
soap.
Mm.
So this is now where we start accumulating our digital apothecary for the hub.
Mhm.
All right. So
So-
for oh yeah, go ahead.
I'm just going to say for my go-to always with the kids was chamomile. You know, it's, that chamomile has been so soothing.
So you just infuse the water with it?
Yeah, and then calamine lotion is like a game changer.
Yes.
Calamine lotion is always like, just my kids would laugh at me. What are you talking about? It's like it works.
Is that the pink one?
Yeah.
Yeah. Okay. I wonder what makes it pink. Do you know?
No, I don't.
Calendula is also good, I think.
Angela, yes, I've heard of that. How about have you guys heard of neem? Neem
Yeah.
leaf?
Yes. Yeah.
Does it work for
Neem.
fungal?
Yeah. And tamanu oil also.
Can you spell?
TAMANU
Oil
oil.
for fungal?
I'm not sure. Oh, and you know what? Actually, I had ringworm on my foot, on my leg, and I've been through the doctors. That was way in the back in the past. And I used, oh gosh, what is that called? Oregano oil. One application, gone completely.
Okay.
Topical oregano oil for ringworm.
Okay.
Mm.
My mom, I remember her, she would use dilution of apple cider vinegar
Yeah,
when we were young.
Yeah, that's
yeah, that's a good one.
So if you have any other suggestions, then we'll add that to our list. Soothing and like soothing balms,
Aloe.
Lavender.
lavender,
aloe vera.
Aloe, yeah.
aloe vera, yep. Cucumber.
Oh, yes.
Use that. I know some countries use yogurt.
Black tea bags.
What's
Mm.
that?
Black tea bags.
Oh, yes. Does it necessarily have to be black tea or any tea bag?
I think black tea is the better choice.
Okay. Now, what do you suggest for anti-itch aside from calamine?
Mm.
Castor oil.
Yeah, coconut oil with a blend of lavender or something would help too.
You love lavender, hey, Fiona?
Yeah, lavender is.
Hypochlorous acid.
Oh, yes. Is that an anti-itch also?
It's an anti-itch, you bet.
Okay.
It's a natural disinfectant, salt-based.
Awesome. Okay. And oatmeal baths for,
Right.
you know, I would usually tell moms for their eczema or diaper rashes. Okay. Now, barrier protection. To repair the barrier. Once you, so what, as if you notice, we are going layer by layer. So first remove the trigger and then cleanse the area and douse whatever inflammation is going on before you can even seal the barrier. So now we're on barrier protection.
Zinc.
Zinc oxide, okay.
Mm.
Your shea butter,
Yeah, she's great.
your
Mhm.
vegetable-based oils, I guess.
Mhm.
Your favorite veggie oil.
Coconut's
Coconut oil,
great.
yeah.
Yeah.
Can honey do it? I don't know.
Manuka.
Manuka honey. Okay. Anything else? Anything else that you want to add to your universal management strategies? Why? Why are you laughing?
I love it. I love it.
My intuition, it keeps coming to like the cabbage cauliflower. You know how when the breast is filled with milk and it's so uncomfortable, and the
I
sort
did-
of
I
the
did that.
solution was
Yeah.
that cold cabbage leaf, you know?
Yeah, I did that. I did that.
Yeah.
It's soothing.
And
It's
potato,
soothing.
potato skin or the potato whites.
Mm.
I know they don't believe, GNM doesn't believe in skin cancer, but sun protection, I would probably add if you're really going into a very
Mhm.
hot area. Like
Mhm.
that, maybe. I think it's gonna be a personal choice if you want to. Since GNM, I haven't been putting my sunscreen.
The natural SPFs for skin. Like it's zinc based. It's beautiful.
Mm.
And
I
I think
also heard strawberry and watermelon.
for sun.
When you drink strawberry and watermelon together, it boosts, I guess, the sun protection properties of the skin.
Oh, really? Okay.
There's,
But you have
there's
to
some
drink it.
paper. Wow.
Nice. Didn't know that.
You
That's
have to
great.
drink though, not on the
You
skin.
drink it. Yeah, you drink it. Mhm.
Okay, awesome.
Thank you.
Add some mint and it's gorgeous drink.
Yes. Maybe we can do that for our spring party.
I guess it's
Nice.
alkalizing.
I wanted to mention honey.
Yes.
I once had an infected finger and it looked like it was, it just, it did not look healthy at all. So I put honey on it and I wrapped it for the night and the skin was pink in the morning.
Oh, wow.
So
Yeah.
it's really helpful for that.
The
Yes.
San people in Southern Africa, they use honey and they chew the leaves of the camel thorn, which we probably can't get here in North America. And then they take termite. If it's a big laceration, they'll take the termite. They'll make the ant bite the span of the cut, and then
Wow.
snip the head off and just stitch with the termite heads all the way down to the end of the laceration.
Oh my
Like,
god.
like immersing necrotic skin in maggots.
Yes. Or
Now,
blood.
Fiona, do they use the honey for sunscreen?
No, they don't use anything for the sun. They're not afraid of the sun. They lived under the sun for hundreds of thousands of years, right?
Mhm.
And there's never skin cancer, right? There's no
Mhm.
skin cancer among those people, right?
Mm.
So now you have a client, you've done this, and the rash is failing to improve. So now we go to, when do you refer? How do you know if you're going to refer? So first of all, if it's failing to improve, right? If it starts to worsen. Improvement, I would suggest maybe wait 2 weeks, if that's how long a typical healing of a skin lasts. Beyond 2 weeks, you're going to months, then that might be something to think about for referral. What else? If the condition spreads beyond the area that you saw it initially, if it's starting to change in color, in texture, in shape. So anytime that you feel that it's progressing, then refer. If there are signs of persistent skin breakdown, if it starts to keep opening more cracks, or the ulcer is deepening, or you're starting to see blackish discoloration. Another thing is if you're seeing an unusual bleeding, you will know anyway, because your intuition are so strong within each of you. You will know when it's time to refer. Okay. The third is if it is associated with systemic symptoms, because that one you cannot manage at home anymore. So fevers, mild fevers are normal, but if there are spiking in fevers, chills, think about, for example, meningococcemia. Maybe it has gotten into the meninges or meningitis associated symptoms. If the individual is unusually weak or fatigued or just unwell, if there are joint pains, joint swelling, okay. And of course, if there are breathing difficulties or if you see the lips getting bluish, so think about anaphylaxis. If it's associated with usually respiratory symptoms or digestive symptoms, think allergy, think anaphylactic shock, impending, because sometimes it starts with digestive issues first, tummy ache first, before they go into anaphylaxis. Right. The next thing to consider to refer is when it affects the critical or the sensitive areas, like your face, of course, your sense organs, your eyes, your mouth, the genitals and the anal area. What else? Okay. The next one is if you have a suspicion that they reacted from a new medication that they may be taking. So, because they need to bring that up with their provider. Usually it manifests as swelling of the lips or angioedema, we call it. All right. And the last one is if it's a pediatric. I know you have all, I think all of you had children. Yes, you know some about rashes in children. However, I would caution you, especially if it's a newborn, especially if they are 3 months or less, they decompensate very rapidly, even from a simple rash, because you never know, it can tip the balance for them. So I would, in this regard, caution, work on the side of caution and just refer if it's a pediatric age. All right. Now, and when you don't know, refer.
So that's the interesting part, like with the newborns, and then because in one of your slides you had like the measles, right? So then let's just imagine you have a parent that is non-vaccinating, and now the child has a rash, and it's looking like it is potentially the measles. So what do you say as a provider in this case?
I would assess the vital signs.
Right.
If the child, and again the age, if it's 3 months or less, I would suggest don't even think about managing that child at home unless you're averse, you're well versed.
Yeah.
If it's an older toddler,
Right.
I would assess the vital signs. If they're able to eat primarily, if they're able to be nourished at home, there are no high fevers. If it's just mild fever, they're comfortable, they are able to nourish themselves, I would watch and wait.
Okay.
Yeah.
Perfect.
Right. So now, say you were presented with a rash and you don't know, you just don't know. So now you refer, you're thinking of referring. But before you do that, you of course have to tell your client, we're going to refer. So in order to avoid another DHS, what do you do? So these are just guidelines.
Don't instill fear.
Yes, you don't want to do that. You don't want to do that. So these are just guidelines to think about when you are faced with that mom who is panicking now about the child and she's your best friend. What do you do? So normalize the concern, emphasize body's healing capacity. Now we're gonna do this as a couple exercise. So I'm gonna ask you, I'm just gonna start right now. So Shar, pretend that Dylan is in front of you and she's a panicky mom and you don't wanna add on to that layer. Can you please offer a script, a simple 1 or 2 liner on how you would normalize the concern for her?
Okay. Well, your child has an innate ability to heal. You must remember that. And what's the most important is your reaction. So however you're reacting is important. So you need to be calm. You need to be coming from a place of all is well. And whatever you do moving forward, you're reassuring your child that they're going to be okay. And as you're doing that with your child, you're actually comforting yourself at the same time.
Perfect. Thank you. Now, Fiona, Gosha is in front of you. What script can you offer to emphasize the body's healing capacity?
The body is designed to come back to a state of balance and restore itself to its divine blueprint. And it has been doing this for as long as humanity's been alive. We can trust this, and at this point we we probably just need to add some supports for the body. And this is where I come in, and we take things step by step.
Beautiful, beautiful. And Gosha, how can you confidently provide the next steps for, let's see, who else is here? Amber, for Amber.
So, oh
Because
gosh, I don't know how to say it, but
you're planning to refer her now.
yeah, so I would advise you to go and follow up with your healthcare provider.
Without instilling fear, because she's gonna ask you why. Can you not help me?
Oh my gosh. I'm not sure how to say it. It got me off guard.
We can say as providers, because I know, Gosha, I know where you're coming from. We're just so used to, okay, this is what we're gonna do. What we can say is, well, while I'm able to provide you some insight, I'm not necessarily an expert on skin, and it's just going to be best if we have more eyes on it to ensure the best approach. So it's just important for a doctor to look at, not because it's something to worry about, but we just want some clarity on this condition.
Would we all?
Just to be, I don't know, again, safe,
Yeah.
right? But that might instill fear. So
Would we also
that's a
say
tough
something
one.
like, we're going to be there with you? Like, this doesn't mean I'm just going to hand you off and you're doing it on your own. I'll be there with you every step of the way. This is our next steps will be to go and do this, and we'll work through this together, type of thing, so that you're not all of a sudden cutting you off after they've come to you for the first, like, to begin with.
Lovely. Lovely. And then, Dylan, how would you reinforce calm?
I don't know. It's hard for me, but I would probably say that we've looked at some different things and kind of reassure the person that they've been doing everything that they believe intuitively is the right thing to do. And in my case, I would ask the person, I would reinforce the idea that we are collaborating together, and that her intuition is important, and ask her how she feels about taking the next step to consult a medical doctor about what's been going on. Yeah.
What were you worried about? That was perfect. All right. So now you're referred, or now you've decided and the mom agreed for that referral. When you refer, how do you refer? And I offer this mnemonic because often when we get referrals from community providers, so I would hear comments like the holistic practitioners, for example, that they're not recognized by the medical field. Well, part of that is because when they refer to the medical field, it's not a complete referral. If you want to be seen as a professional, then act like one. And I provide this for you because I'm coming from that perspective now, that what am I expecting from you if you're referring to me, so that I can recognize you as an equal.
Yes.
Or I can recognize you as a professional and not like a mom. Not that, you know what I'm saying? Not like a simple household family member. So assert your professional capacity because you are professionals. And by following a particular outline that we are familiar with, like the SOAP, then we're speaking the same language. Then it's easier to communicate. Whatever it is that my plan is for that patient as a doctor, then it's easier for me to communicate to you because I know we're of the same mind. I know that we're on the same page. Does that make sense?
Have a protocol, like a standard protocol.
This is something that an idea that I'm offering. You don't have to use it, but it's just a guide, a template. All right. So if you can remember the cases that I presented last time for the digestive, it starts with the patient identifier always. So the name and the age and the gender. And then next to that is the chief complaint, or what are they coming in for, which is a rash. And if you remember the SOAP format that I had shared with you, the S is all patient's account. This is all about the patient from their mouth. The O is when you come in, when you start examining the patient. The A, assessment. So S is subjective, O is objective, A is assessment. This could be a diagnosis or just your assessment on what's going on from the GNM perspective and what's the plan, what's the management. So the mnemonic that I offered you earlier, which is rash, skin, rash will apply to the subjective portion. Skin will apply to the objective portion. So for the subjective portion, the mnemonic is rash, which is, and again, you don't have to pattern after this, but I'm just trying to show you a way to present a rash. What are the information that that medical professional will be looking for? So R for region and distribution. Where is the lesion? So give the area. Is it limited to one area or is it spread out? Is it symmetrical or mirror image? Does it follow a pattern? Is it a linear pattern? Is it a circular pattern like a ringworm? Poison ivy has a particular pattern. It follows where the leaves or the branches grazed it. So does it follow a pattern? That's for R. For A, is the patient presenting with pain, discomfort, other symptoms from other body systems, respiratory, digestive? The S is the patient story. When did it start? How long has it been? Has it changed over the timeline? How has it changed? The H, history. Exposure, travel exposure, if they were traveling, for example. What interventions have been done prior to them coming to you? Did they apply any other remedies prior to them coming to you? Did they try any home remedies? So all of that, you can use that mnemonic as a guide when you're eliciting a history from a patient. Because it can be any, like when they come to you, they're rattling keywords. And how do you organize that in your brain? So this is just one of the guides that I offer. So you can organize all the words that are going to come from their mouths. Now, so you now have a story. I'm going to present to you a case. And just follow along. I don't have a slide for this one, but I'm just going to present it to you so that you can picture how this mnemonic plays out in a template. So you have in front of you Juan, a 50-year-old male. He's coming in for a rash. His medical history, what he says is, I have a rash that is located on both my forearms, and it's a mirror image of the other. I have some itching. Sometimes it's painful if I keep on scratching. I don't have any fever. I don't have any pus. There was no pus that I could see. So that's the A. For the S, it started about 3 weeks ago. Initially, they were small red patches, and now they are scaly, and now they're starting to expand beyond where they originally started. And when you ask about the H, the history, the exposure, oh, I'm a gardener. I'm exposed to plants and chemicals. I have had no recent medication changes. I did apply a moisturizing lotion, but I didn't see any improvement. So as the patient is telling you the story, you're categorizing it now in terms of the mnemonic. So that's how a subjective template can play out verbally in real life. Now we go to the objective. So now it's your turn to examine that rash. Now in the objective, because this is what you're going to write to the doctor who you're referring to. This is the meat when I'm assessing a client from a referral. The subjective and the objective are the meat. It comprises about, I would say, 85%. Once you have a good subjective and objective, you can pretty much make a diagnosis even without doing blood tests. So the meat of the report is in the subjective and the objective. So now you're seeing the rash. The S is for size, shape, and surface. So take out your ruler. It would be useful if you carry those retractable rulers. We usually carry them in our pockets. It's very useful. So what's the size? Measure it. What's the shape? And touch it. What's the surface feeling like? Is it rough? Is it smooth? Is it scaly? Now we move on to the K. K for color. What's the color? Is it red, brown, white? And what's the border? Is the border well defined? Can you actually trace it with a pencil? Or is it kind of irregular, like you can't even map it out? The I is induration. That is it raised? Is it thick? Is it flat? Or is it depressed? Is there like a cave feel to it? Does it feel firm or soft? Check the temperature. And if you feel it, is it tender to touch? Do they grimace? Watch their reaction on the face. Do they grimace? When you're moving it, so you're pinching it in between your thumb and forefinger. When you move it, does it move or is it fixed? So the mobility you're checking. So all of those are coming into the objective. And the last for the N, is there only one or are there multiple rashes? And can you see a pattern? Is there a major rash and then satellite rashes nearby, like a big one and then smaller baby-like ones around it? So how does it compare to the skin and what have been the changes? Now, so you have now the subjective and the objective, which you will write. You can handwrite, you can type. Again, you're the professional, you're trying to refer professionally. So perhaps you may want to type it. The next one, still under objective, is how does it appear? So you can describe all you want to me, but it will be very useful if you can attach a photo. Now we have a tool that we call dermoscopy, which is a zoomed in version of any rash. It is a luxury app on an iPhone. It is subscription. You don't need to have this one, but I pointed out because when you're taking a photo, and it can be with your simple iPhone, you don't have to have this app. When you're taking a photo, please put a ruler beside that rash so that that provider can determine how big the rash is. So you can describe it to me, but again, unless you measure, you're just guessing. So this is a very useful tool to have beside a rash, a ruler. And then attach it as your PDF file or however way you want. Now we come to the A of the SOAP. The A, you're not required to diagnose, but it would be useful, again, from a professional perspective. If I see you put an A to that, oh, I believe from my experience that this is what my client is dealing with as I refer to you, it would really just add conviction on my part that, oh, I'm not just dealing with, Karen on the street. I'm dealing with someone who's professional. So I need to be professional as well when I'm communicating with him or her. So you can add your insight. What do you think it is? It can be wrong. We're not expecting you to be right, but it does add that layer of professional flavor. And then you write on that A, how urgent is this? Do you want it ASAP, in 2 to 3 weeks, whatever, what have you? And maybe add as the last step, can you please contact me for, to discuss, because I would like to be able to support this client if you send them home after, because I'm going to be the one dealing with them in their conflicts. So can you please contact me for this number so that I know we're on the same page when you discharge the patient from your clinic. So I present now the case that we have, 1. So you observe the rash. It's a plaque, and the largest that you've measured it is 5 centimeters. It's circular in shape. Some are oval, most are circular. It feels rough to touch. It feels scaly in other parts of the rash. It has a red base, what we call erythematous, or red, inflamed. The borders are somewhat defined. You can trace it with a pencil. When you touch it, it's raised slightly from the level of the skin. It is slightly warm to touch. It's not tender. And there are multiple, it's not just one rash, there are multiple. Some are smaller than others. And you attach this photo. So as the last step on your report, the A, assessment, what do you think one could be possibly having? So the history is he's 50 years old. He's a gardener. Yeah, it started 3 weeks ago. He was gardening and he was exposed to chemicals for fertilizers. He is otherwise healthy. He takes no medications. Any guess as to what he could be having?
If he's been exposed to chemicals, I'm thinking contact dermatitis of some sort.
Yes.
That's what I tried to say. Sorry, I was in mute.
Yeah, so you will write that as in your assessment, the SOAP. You're not expected to write the P, that's why you're referring, right? The P is for the doctor, but the A, the last one, you can just say, it is my professional opinion that he may be suffering from. And then I will wait for your further assessment, something like that.
And Richie,
yeah.
When you ask for some follow-up information from the doctor, like I can see you doing that as a physician, but there's the patient confidentiality thing. Can you explain how that would play into this?
The very fact that you are the one referring, it is an unspoken agreement from the patient that you are privy to that conversation or to that report from the doctor. So if I'm the doctor and I'm accepting your referral, it's just courtesy for me to give you a copy of my report because you're the original referral person.
Okay. That's
Not all doctors do it though. Not all doctors do that.
Yeah,
That's why I'm encouraging you to be proactive in this way, because when we get referrals from holistic, it's usually through the mouth of the patient. The patient will say, oh, my naturopath told me to see you. Okay, then I don't have any responsibility to contact your naturopath. But if the naturopath picks up the phone and actually calls me, oh, hey, I have this client, I'm so concerned. To me, that tells me you're really concerned. Thank you, because we share that same concern. And as I am discharging the patient, you are more close to that patient in reality than I am. Then I would be more likely to pick up that phone and say, "Oh, hey, naturopath, by the way, I'm discharging. Thank you for your referral. This is my assessment. This is what's going to happen." So that it also relieves me of any responsibility. It's like turning over back to you. Now it's your turn to do the conflict stage.
And have we talked about what kind of person, professional to refer the patient to? Like in this case, you mentioned naturopath.
Who are the referring people?
Yeah, I'm wondering, how do you decide who to refer to? Perhaps I'd ask my client if she has seen a naturopath, and
so
maybe go to
you
that.
can work with your client. You can ask, okay, I need a second set of eyes on this for clarity. Who would you prefer me to refer you to? Who do you have more confidence with? Is it your naturopath or your GP?
Okay.
So again, they are the driver of this bus. So ask them, who would they feel more comfortable? Because it has been proven the treatment is more effective if they have more confidence in their provider versus
Right.
refer them to some surgeon who they've never met. They will listen more to whoever it is that they that they have rapport with. Think about that naturopath may be in the same boat as you, may not know about skin. So you may just be adding a second layer of delay. So think also, if it will delay, then why don't you just go directly to a walk-in or the GP? And that is it. That is it.
Can I get you to go back to the rash one again, please?
This one. Oh.
No, two back. Back two more. Or three more, I guess. I was listening to you and didn't write everything down, so I just want to write it down.
So if anybody has any questions.
Now, just kind of going back to, like, I know you're going through this subjective, but I'm just curious about this gardener and, you know, the potential of exposure to chemicals, but then even thinking a little further about his personal life, right? Like if we've been gone through like some sort of separation or problems at work. I mean, those would have been things that you would have discussed prior to doing your assessment, I'm imagining. Is that correct?
This is a template just for referral.
Right.
It did not absolve you from the responsibility of digging deeper with this client about their conflicts.
Right. Gotcha. Okay.
But you are in a very unique position because, as you know, what will the GP do? We'll just look at the skin. We'll not look at the conflict.
Right.
Turning back to you, turning over to you.
Right.
Yeah. And that's just you, when you're doing the referral, you're just giving them the information that pertains to what they're going to be looking at. Because I got stuck on the same thing too. I'm like, why are we getting all this information when this all has to do with a conflict that they've run into? But this is after the fact. This isn't, yeah.
This is just specifically for referring
because we're at that place where we feel like we've opened up all the doors and we're not being able to feel like we can put some closure to it, and things are getting worse instead of better. Is that correct? Yeah. Okay, gotcha.
Just that, because you will still sit down with that client at some point once the rash is. So again, you determine, do I bring it up or do I not? The rash is healed. So it's now up to you and your relationship with the client if you bring up the conflict and do a deep dive or not. But at the end of the day, you're the last person that they supposedly will see before they go back home and things are back to normal.
So the part that I think that I got stuck onto was like as soon as you'd said exposure to plants and exposure to like the fertilizer and chemicals, like that's where I got stuck. And I'm like, but that has nothing to do with the biological conflict. So, but then I was like, oh, wait, we're talking to a doctor or somebody that is going to be asking these questions. So we're just giving the additional information that they might be wanting.
Yes, because they don't know that they don't know the germ layers and the conflict. They don't know. All
Yeah.
I know is this.
So we talk about the germ layers and get all that information. And when we're talking to them, we probably wouldn't have thought about exposure to chemicals, or the plants might have, like, you might have touched something that would have been that would have caused this on your skin, because we're in GNM thinking about conflicts and stuff like that. So when we get to the point where, like, okay, we have to refer them, then you have to change focus and go, okay, now what things could they have been come into contact with? What's in their environment? And those might not be things that over the last 2 weeks we've been talking to them about.
Yes, it's not, because that only you know how to approach that from a GNM. The doctor will not. But what you're trying to do is make the doctor's life easy, just to streamline the process. I mean, the doctor will still do her own history. The reason I present that is not because without that we will do fine. I will do fine. I will get my own history anyway. But the reason I'm presenting it is because if you want to be considered a professional in their eyes, this is one way that you can assert yourself.
Yeah.
Right, Gosha?
Yeah.
Yeah.
Because we dismiss so many holistic practitioners thinking that, you know.
Yeah, always. It's like, no, that's not part of the healing here in the hospital. It's like, even when they come with supplements and stuff, they completely discontinue all their meds. Like, if it's not pharmaceuticals, it's automatically discontinued, all the stuff that patients are on, like, without even considering stopping. You know what I mean?
So we are rising to be at the forefront now.
Love it.
Collaborating. Yeah.
We are done. Right on time.
I'm a fan. Sign me up.
Thank you.
You're welcome. Any
Thank
other
you so much.
Thank
I
you.
had a really hard time hearing. I don't know why my computer is such low volume, and so I kind of missed a few things, but there will be this is recorded and I can just log back in, right?
Yeah. Yeah.
Okay.
Gosha, you were really loud. Like, your microphone is really loud. I wonder if it was picking up background noises and we weren't coming
I had
through.
few people come through the house, so I was constantly on mute. Unexpected guests. I'm like, oh my gosh. And then the dog barking. It's like, okay. So, okay, I'll have to look at my audio.
Yeah.
So if you guys are up to it, next Saturday we can do a review of the breasts. Same time.
Yes.
Yes.
But bear with me because I wasn't present for her presentation, so I'll have to base it on the website. I don't have notes from her either because it's still with Daylan, and I won't see Daylan until in 2 weeks.
Okay.
Unless I drop them off later today.
I'll see if I can send you something, Richianne.
Okay.
Yeah. I mean, the text, that would be helpful.
I hope that helped.
Thanks so much, Regina.
You're welcome.
Thank
Is it
you.
helpful to you, or is it redundant? Because I don't want to be redundant.
No, it's very helpful
Oh,
to get your perspective because you have that, the medical perspective, for me at least that's the way I view it.
Love it. I love it.
Yeah, me too. It's like another perspective, and it's very, very
Very
helpful.
focused on the main parts, really condensed, focused, so it clarifies it well.
Yeah.
And I'm hoping that it solidifies whatever theory she presented.
Mm.
Right?
Mhm.
It reinforces.
Richie, I will drop off your
Yeah,
book.
we're saying bye-bye now.
Couple
See you
of
next
hours.
Saturday.
Bye-bye. Love, love, love.
Thank you.
Thank you, everybody. Bye-bye.
Bye.